Welcome back. Today we're diving into an explainer that is literally a survival guide for your practice's revenue cycle. We're mastering how to protect your hard-earned money from evaluation and management or EM claim denials. I'm stepping into the role of your expert medical coding instructor today to give you a complete tactical playbook. If you're dealing with unpaid claims, you know it's a total battlefield out there. So we're going to look exactly at how to manage these denials, perform root cause analysis, and lock down absolute revenue cycle integrity. Let's get right to it. Here's our tactical roadmap for today. We'll be hitting refusals versus denials, the top denial drivers, RCA touchpoints, corrected claims versus appeals, payer downcoding, and finally, key metrics and safeguards. All right, kicking things off with Section 1, refusals versus formal claim denials. So, there are basically two main roadblocks your claims will hit. First up is a claim refusal or rejection. Think of this like a bouncer turning you away at the door. It's a front-end clearinghouse or a technical edit failure that gets caught before adjudication even happens. We're talking missing subscriber IDs, invalid NPIs, or unmapped modifiers. It's usually a quick technical fix. But then we have a formal claim denial. Now this is much more serious. This means you got inside, the claim processed through adjudication, but they still kicked it out and refused to pay due to coverage, clinical, or coding determinations. A formal denial means we have to dive deep into the clinical documentation to fight back. And when that formal denial hits your desk, the payer communicates through these cryptic little codes on your explanation of benefits. These are CARC, or Claim Adjustment Reason Codes, and RARC, Remittance Advice Remark Codes. Basically, these codes are the fingerprints of your revenue thief. They tell you the exact reason why the payer is withholding your money. Moving right along to Section 2, let's talk about the top EM denial drivers. Consider this your absolute most wanted list. Knowing these specific codes tells you exactly what went wrong. For instance, CO50. That means the service is deemed not medically necessary, usually because your ICD-10 diagnosis just doesn't justify the CPT level you billed. Then there's CO97, which is a massive one. It means bundled or included services, typically caused by billing multiple EM codes on the same day without using modifier 25. CO151 hits when your medical decision-making or time documentation was inadequate, and CO16 simply means the claim lacks information entirely. Zooming out a bit from the specific codes, we can see the broader categories actually driving those denials. Lack of medical necessity is a huge culprit. If you bill a high-level 99-215 office visit, but only link it to an unspecified headache diagnosis, an AI scrubber is absolutely going to flag it, resulting in a swift denial. Modifier denials are also rampant, especially the improper use of modifier 25 for a separate E&M service on the same day as a procedure. We also see a lot of automated downcoding, bundling conflicts caught by NCCI edits, and honestly, just missing timely filing deadlines. Which brings us to Section 3, Root Cause Analysis, or RCA Touchpoints. We literally have to trace the life cycle of a claim like a detective to find the breach. Was it step 1, a documentation issue where a provider just cloned a note or missed crucial MDM evidence? Was it step 2, a coding error where someone selected the wrong level? Did it fail in step 3, billing with an incorrect place of service code? Or step 4, did it violate a specific payer policy altogether? When you break down this entire framework, categorizing the root touchpoint is absolutely key. Whether it's a coder error, a provider documentation gap, or a payer policy shift, knowing the root cause dictates your counterattack. Actually, if you don't categorize the root cause accurately, you're basically just running on a hamster wheel, making the exact same mistakes and losing the exact same revenue over and over again. Let's dive into Section 4, the corrected claims versus appeals workflow. Listen, it is incredibly important not to mix these two up. Use a corrected claim for the simple administrative fixes. We're talking resubmitting a missing modifier, updating an incorrect ICD-10 code, or fixing a typo where there is absolutely no clinical dispute. But when a payer wrongly downcodes your service or challenges your medical necessity, you can't just submit a corrected claim. You have to initiate a formal appeal. That means bringing out the heavy artillery and submitting medical records to contest their decision. So, how do we build an audit-proof appeal packet? You literally have to stack your evidence like a lawyer building a case. Your body paragraph needs to crystal clear explain the clinical necessity by highlighting the physician's narrative. You can't just write, "We deserve to get paid." No way. You have to link the clinical terminology directly to published AMA, E&M guidelines, or specific CMS policies. And lastly, ensure your attachments include the complete, unedited progress notes that actually prove your medical decision-making level. All right, on to Section 5, payer variations in downcoding programs. Here is a major and honestly kind of scary threat right now: automated downcoding. Commercial carriers and Medicare are frequently deploying automated algorithms that just unilaterally reduce your high-level E&M codes. They'll take your 99215 and automatically drop it to a 99213 based on their own internal hidden risk scoring. Their AI just scans for specific missing MDM phrases. Fighting this requires strict tracking and really aggressive, well-documented auditing on your end to challenge these robots and get your full payment back. Finally, let's wrap up with Section 6, revenue cycle metrics and preventative safeguards. Your ultimate target here: a first-pass clean claim rate of greater than 95%. That means 95% of your claims fly straight through the clearinghouse and adjudication without a single ounce of manual rework. It is the ultimate benchmark of a healthy, thriving revenue cycle. On the flip side, you've got to ruthlessly safeguard your operations to keep your overall denial rate consistently under 5%. If that denial rate starts creeping up, you are bleeding significant revenue to administrative waste, plain and simple. Tracking these specific metrics alongside your days in accounts receivable is basically non-negotiable. It lets you spot exactly which coders or which providers might be struggling. And once you know that, you can implement regular clinical documentation improvement, or CDI, feedback loops, so your providers understand exactly how their notes are impacting the billing cycle. So how do you actually automate this defense? It's all about integrating an AI-powered pre-submission scrubber directly into your workflow. Put it right between the EHR documentation and the final billing system. A good AI scrubber will detect a high-level visit mapped to an unspecified diagnosis code and flag it instantly before it ever reaches the clearinghouse. It catches those missing modifiers and LCD mismatches so you don't have to. By understanding the fundamental difference between refusals and formal denials, mastering the appeals workflow, and putting automated AI safeguards in place, you truly become the ultimate defender of your practice's revenue cycle. But ask yourself, is your current workflow catching these leaks, or is an algorithm quietly shrinking your bottom line right now? It takes vigilance, but the return on investment is absolutely massive. Don't forget to like, share, and subscribe to Decode Healthcare with Harshil.